Hello and welcome to the Unit 2 lecture on Nursing Process for Nursing Fundamentals. So our core competency is to use the nursing process, and that's what we should be able to do by the time we get done with this unit. The nursing process is used to identify, diagnose, and treat human responses to health and illness. The nursing process is a tool used consistently and methodically with nurses with every patient encounter. So really it's essential that you learn and understand how to apply the nursing process because it really truly is the underpinning of everything that we do as a nurse. The next 3 slides here are your learning objectives for this lesson. There's a lot of them. You know this topic's important. Use the attached sheet listing the learning objectives in E360 as a study guide to prepare for the exam because remember, like we said week 1, everything you need for the test is on these learning objectives. All the questions come from these learning objectives. And additionally, there's also a study guide on E360 if you want to fill that out to increase your knowledge on that as well. So the nursing process is used, like we said, to identify, diagnose, and treat responses to health and illness. And this differentiates the nursing process from the medical process, which treats the illness itself. Following the nursing process allows nurses to provide systematic and patient-centered care, and the nursing process allows us as professionals to use our nursing knowledge, judgment, and experiences to cue in on patterns, signs, and symptoms that the patients show us. When we use critical thinking and clinical reasoning, we're better able to care for our patients. We remember our experiences with patients, and these shape our future planning and analyzing of patient data. The steps of the nursing process can be remembered using the ADPIE acronym, which is listed here, and we've got assessment, diagnosis, planning, implementation, and evaluation. So step 1 in the nursing process is assessment or data collection. Assessment includes a physical examination along with observation skills. So that's like our brief. We walk in the door, we look at the patient, what do we think? Look for cues from the patient. Do they appear short of breath? What's their color? How are they looking overall? We also want to find out, what's the patient and the family's perception of the problem, because sometimes the patient might not understand what's going on with them, so they may be, way more upset than what the situation would seem to warrant, or they may not feel upset at all because they just simply don't understand the severity of what's going on with them. It's important to always validate the data to make sure it's accurate, and that means that we're going to make sure that our observations, our assessments, what the patient or the family is telling you, what all these things show makes sense with one another. And if they don't, then we need to, clarify and try to see where the incongruence is. Data clustering is a way of organizing data and grouping similar data, and this is something we always should do. For example, lung sounds, respiratory effort, and shortness of breath can all be clustered together, and they should be clustered together because that helps give us an accurate idea of what's going on. Analysis is looking at the data you've collected and applying critical thinking. What does the data mean? You want to make sure you have all the data you need to make a plan of care. So for example, if your patient has a fever, do you have the results of the complete blood count? The white blood cell counts indicate infection, so if you're missing this part of the data, well, you might miss an important part of the puzzle. You also want to sort out normal from abnormal data. Like we said, look for patterns in the data. This is another way to apply critical thinking. So for example, the patient's blood pressure is elevated today, but you look back in his chart and the last 3 blood pressure checks were in normal range. You got to think about what that means. Maybe the patient is just having an emotional day and that's why the blood pressure is elevated. There are 2 types of data. This is subjective and objective. Subjective data is what the patient or family reports, and these are the symptoms. And this is charted the same way it's reported exactly. So we say the patient states, and then in quotation we're going to write what they state, end quotation. The objective data is what you observe during your physical assessment, and these are the signs. So for example, a sign of nausea might be retching, while a symptom of nausea is the patient stating, in quotations, I feel nauseated. So when we are going to start our assessment, we're going to start with the initial interview. And like I said, you want to look for cues through observation. We want to look at the patient's overall appearance. And we're going to introduce ourselves, and we're going to gain the client's trust. And this is very, very important because the client's more likely to tell you details, especially if they're private, personal, maybe embarrassing details, if you've established a rapport with the patient first. Direct closed-ended questions such as "Are you having pain?" allow for a focused, quick assessment, and they're to the point. Whereas indirect open-ended questions such as "Tell me about how that made you feel" gives the patient an opportunity to explore their feelings and explain what they need to tell you. It's important not to brush over questions. So if you have a patient that says, you ask them, "What's your blood sugar been running?" and they say, "Well, I haven't really been checking my blood sugar," you want to look into that, ask questions to try to get to the bottom of why. You maybe ask them if their glucometer works, ask them if they have Lancets, ask them if they have medications, maybe see if they even really understand how to check their blood sugar. So here's a couple of questions you can ask yourself just as a stop and review. You can hit pause and just make sure you can answer these questions. All right, so step 2, after we've assessed and analyzed, we're going to state our conclusions of our data in the form of a nursing diagnosis. It's important, remember, to use nursing diagnosis and not medical diagnosis. So for example, a headache is a medical diagnosis, but your patient's here with a headache. So what are we going to do? You can still develop a plan of care using that information. You just can't say, they have a diagnosis of headache. Instead, you're going to say, as a nursing diagnosis, maybe your patient's having acute pain. So how do we separate a medical diagnosis from a nursing diagnosis anyway? Medical diagnoses are related to disease processes and their pathology. It's outside of a nurse's scope of practice to form a medical diagnosis. Examples of this would be diabetes or pneumonia. A nursing diagnosis, on the other hand, describes how the person responds to their health problem or life process. This does fall within the nursing scope of practice, so we can do these diagnoses. So if you have your patient that's here with diabetes, we can't diagnose diabetes, but we can diagnose alteration in metabolism, which goes along with diabetes. There's 3 types of nursing diagnosis. We've got an actual diagnosis, which means the patient has the problem right now. So for example, the patient has a headache right now. So the diagnosis would be acute pain related to complaints of globalized headache as evidenced by rates pain as an 8 out of 10. An actual diagnosis has to be in PES format, the problem, etiology, signs, and symptoms. So it includes the problem, what contributes to the problem, and the signs and symptoms of the problem. An at-risk diagnosis means the problem isn't here quite yet, but it has a really good chance of developing. So for example, a patient who is immobile is at risk for skin breakdown. So the diagnosis would be risk for impaired skin integrity related to immobility. And note here that the signs and symptoms are not needed for an at-risk diagnosis because they don't have the problem yet, so they're not going to have the signs and symptoms of the problem. Then a wellness diagnosis focuses on a patient's strength. So for example, a newborn with a feeding disorder might have a diagnosis of readiness for enhanced family coping because the family may show signs that they're ready to figure out how to care and deal with this newborn with this problem. An example of an inaccurate nursing diagnosis would be lack of adequate nutrition. The diagnosis should be imbalanced nutrition, less than body requirements. So it takes a little bit of practice and finesse to get the hang of what's approved and what's not approved for a diagnosis, but you can use your resources to just practice with that. The Lippincott website and your nursing diagnosis handbook, and also in your textbook Craven, there's some good examples on page 222 of accurate and inaccurate nursing diagnosis. And then 224 to 226 has some good Examples of nursing diagnoses organized by functional health patterns. So just remember the key takeaway that nursing diagnosis is not medical terminology, symptoms, patient needs, or treatments, and it's certainly not a medical diagnosis. This slide breaks down the actual components of a nursing diagnosis, and we're going to discuss this more in class also, but this is just to give you a general idea of the components. The problem is the patient's NANDA diagnosis. The etiology is what contributes to the problem and must be treatable by nursing. And then the signs and symptoms are the defining characteristics of the problem and not the etiology. So it's related back to the problem. And recall from scope of practice last week that the LPN can collect the data, but they can't analyze the data and they can't evaluate either. So LPN can't make the nursing diagnosis, but they can carry out the interventions as long as they fall within the LPN scope of practice. So take a break here, pause the slide, and just look either in Lippincott or in your nursing diagnosis handbook and try to figure out one nursing diagnosis complete in PES format for a patient admitted with stroke. And then we'll be prepared to share our diagnosis in class. So the next phase or step in the nursing process is planning. During the planning phase of the nursing process, we write the care plan. Think of it as the playbook for the nursing care for the patient. The nursing care plan is the culmination of data collected during your assessment, the nursing diagnosis, outcomes, nursing interventions, and evaluation of the interventions. It tells staff how to manage the patient based on the patient's individual needs or problems. So it is very patient specific. And when we're planning, we're going to set priorities for our interventions. And this is where we're going to think back to our discussion last week of Maslow's hierarchy of needs, because this directly applies to nursing interventions and care planning. We always want to attend to high priority life or death needs first. These are anything that would result in harm to the patient or others, such as respiratory distress or hemorrhage, which is a significant bleeding. We want to consider what the patient feels is a high priority too, and if we can work with that, we're going to fit that in with our high priority interventions. Sometimes though, like with a patient and family, what they think is, super important to them, and they'll fixate on one thing, like, the patient needs turned, the patient needs turned, the patient needs turned, and what we're thinking in our head is the patient is so very, very sick that if we turn them, they won't have a blood pressure anymore and they could have a cardiac arrest. So we need to kind of weigh those and really be a patient advocate and look out for what's best for that patient, but always take into consideration the patient and family. Intermediate priorities are then addressed next. These are things that aren't life or death, but they really should be attended to, such as imbalanced nutrition. And then low priorities can affect the patient's future, but aren't necessarily pressing, so they should be addressed last. So without a measurable outcome, which is also part of this planning phase, it's really difficult to evaluate if the interventions were successful or not. There's two types of outcomes. We've got outcome goals, which are broad, such as the patient will have a normal bowel function. But then we have outcome criteria, which are SMART, which are specific, measurable, achievable, realistic, and timely. And these are related back to the problem they're here with, or the P of the PES format. So if the problem's constipation, the outcome goal is going to be broad, like the patient will have no signs or symptoms of constipation, but the outcome criteria should be more narrow focused and measurable, like the patient will pass 1 moderate soft BM by discharge, rather than simply saying the patient will have a BM, because that's not very specific at all. Notice how much more detailed the outcome criteria is. The outcome criteria is how we know the outcome goal is met, and the outcome criteria is more related to the E, or the as evidenced by, and the outcome goal is more related to the P, or problem, in the PES nursing diagnosis. Nursing interventions are anything the staff does for the patient in the plan of care. Intervention should be safe and appropriate, achievable, in line with the client's belief systems, and align with other therapies and conform to current standards of care. Each nursing intervention should be evidence-based and should include a rationale. Please, please, please cite your resources to show your interventions follow evidence-based practice. In this class and in your clinicals and everything else, anytime you're using a care plan, you really, really, really need to make a source. Evidence-based means that there's research or evidence to support it, so we know that it just didn't come out of thin air. And it also must be something that falls within the nurse's scope of practice. So these are the types of interventions you're going to develop in your care plan. Independent nursing interventions are interventions that nurses are licensed to implement based on their education and experience. Provider interventions or provider-initiated interventions, these are interventions that require a provider's order or protocol, but they also require nursing knowledge to perform. And then collaborative interventions require a multidisciplinary approach to complete. So next, we've done our planning and we move on to implementation. Implementation is the action phase of the care plan. This is where all this planning comes together and you actually perform the interventions you established. It's collaborative, so it's not just nursing doing these tasks. Performing the intervention allows you to reassess the goals. You can make sure that the intervention is relevant and your patient understands what's to be expected. This is very important. Be sure to document what's done, and the nurse is responsible for teaching the patient and family about the interventions. This is something that you're not going to delegate to the CNA or to anybody else. This is something the nurse really needs to handle. The care plan is designed to engage the patient in a partnership with staff to achieve the goals, and engaging and involving the patient is what makes it patient-centered care and makes the patient more likely to be compliant with the plan. You need to tell your patient the goals and you need to tell them why. You need to give them rationales. A patient with severe surgical pain is more likely to cough and deep breathe if they understand that they're doing it to prevent pneumonia, rather than if you just say, hey, you need to do your coughing and deep breathing, because all they're going to think in that case is, that hurts and I don't want to do that. So take a few minutes here again, pause and answer these questions just to make sure you're on track with where we're going so far. So we've implemented our care plan, and now we come to the final phase, which is evaluation. Evaluation takes place after the interventions are carried out, and it can only be done by the nurse. So this is another area where the LPN cannot do the evaluation, the RN can do the evaluation. And this step looks at whether or not the interventions were effective at meeting the outcomes as they're stated and on the date that was specified. Have there been any changes that require the plan of care to be changed? Have goals been met and can be dropped off the care plan? Outcomes that have not been met may have had the wrong interventions, wrong outcomes, or the interventions may not have been implemented correctly. And in any event, they need to have the interventions revised. So at this point, we reevaluate the plan of care. We go back to the planning phase. We rewrite our interventions, and then we re-implement, and this cycle just continues until discharge or until the things on the plan of care have been met. So to recap, today we talked about the nursing process and care planning and writing nursing diagnoses, and we will practice this more in class, but just try to remember for now this acronym ADPIE that outlines the steps of the nursing process. So thank you, and that's it for this lecture, and we will see you guys all next week.